Hello everybody, welcome to the discussion of Pleura Part 2. At the end of this second session, the learner should be able to describe the development of the pleura, describe the histology of the pleura, describe the surface anatomy of the pleura, correlate some of the clinical aspects such as pleuritis, pneumothorax, pleural effusion, and pleural tapping. First, the development of pleura. During week 4, a laryngotracheal diverticulum appears in the floor of the pharynx. It elongates and its distal end divides into two, named as bronchial buds. During week 5, these buds begin to enlarge and each pushes into pericardio-peritoneal canal downwards, laterally, and upward, as half-inflated bag being pushed by the fist. Ultimately, pleuroperitoneal and pleuropericardial folds appear and separate pericardio-peritoneal canals from peritoneal and pericardial cavities, and it becomes primitive pleural cavity. Epithelial lining somatic layer of lateral plate mesoderm adheres to thoracic wall and becomes parietal pleura, whereas epithelial lining splanchnic layer of lateral plate mesoderm comes in contact and adheres with lungs and becomes visceral pleura. Area of continuity between parietal and visceral pleura appears as a pleural sleeve and covers root of the lung and also becomes pulmonary ligament. The space between parietal and visceral layer of pleura becomes the pleural cavity. Pleural histology. Both layers of pleura, that is parietal and visceral, have same thickness. Each layer is lined by simple squamous mesothelial cells with an underlying thin connective tissue layer consisting of collagen and elastic fibers, blood and lymph vessels, and nerve fibers. Things to be noted are that elastic fibers of the visceral pleura are continuous with those of the pulmonary parenchyma, and parietal pleura is separated from overlying thoracic wall structures by endothoracic fascia having variable amount of fats. Now the surface anatomy of pleura. As both parietal and visceral pleura are in contact with each other in the cervical region, so both the pleurae are indicated by a line in the shape of a dome 1 inch above medial 1/3 of clavicle. Anterior margin on left side is again indicated by a line drawn by taking the following points. Number 1, apex of dome of cervical pleura. Number 2, left sternoclavicular joint. Number 3, manubriosternal joint in midline. Number 4, costal cartilage level in midline. Number 5, fifth costal cartilage level along left parasternal line. Sixth point is left sixth sternocostal joint. This leftward deflection is to accommodate the cardiac notch of left lung. Now the right pleurae are again indicated by taking the following points. We start from the apex of the dome, just like on the left side, to right sternoclavicular joint, to manubriosternal joint in midline, to fourth costal cartilage level in midline, to sixth sternocostal joint level of inferior margin of both pleura separately on both the side is similar. First, the inferior margin of parietal pleura is indicated by taking an oblique line around the chest wall by taking following points. Number 1, sixth sternocostal joint. Number 2, eighth rib in mid-clavicular line. Number 3, 10th rib in mid-axillary line. And finally, fourth point is taken as 2 centimeter lateral to T12 spine. Inferior margin of visceral pleura on both sides is indicated by an oblique line around the chest wall by taking following points. First one, as for parietal pleura, is sixth costochondral joint. Second point is sixth rib in mid-clavicular line. Third point is eighth rib in mid-axillary line. And fourth point is 2.2 centimeter lateral to 10th spine. Notable point is that there is difference between both the pleurae. Minimum anteriorly increases gradually as we proceed posteriorly and reaches maximum, that is 2 vertebral levels, at posterior margin reflection. On posterior aspect, both the pleurae on both the sides are in direct contact with each other. Hence, posterior margin reflections are indicated similarly on both sides except one difference at their lower ends. Posterior margin of parietal pleura, as shown on the right side, is indicated by almost a vertical line along vertebral column 2.5 centimeter lateral to spinous processes from apex of the dome, that is C7 level, to inferior margin, that is T12 level. Posterior margin of visceral pleura, as shown on the left side, is again indicated by almost a vertical line along vertebral column 2.5 centimeter lateral to spinous processes from apex of the dome, that is C7 level, to inferior margin, that is T10 level. Notable difference of both the parietal and visceral pleura is 2 vertebral level at the inferior end. Applied anatomy of pleura. Pleura. Notable thing is that parietal pleura extends slightly below 10th rib posteriorly, as shown by the arrows. During posterior approach to the kidney, be careful when exposing the kidney from behind. May open pleural cavity accidentally. Pleurisy or pleuritis. It is inflammation of the pleura which is caused by infections or autoimmune disorders. It produces inflammatory exudate which impairs lubricating function of normal pleural fluid, which leads to roughening of the pleural surface. This roughening causes pain when breathing and pleural rub on auscultation with stethoscope, and the disease is named as dry pleurisy. Both pain and pleural rub disappear when fluid appears in the pleural cavity, and the state is named as pleural effusion. Pneumothorax or simple pneumothorax. It is abnormal collection of air in pleural cavity. Air enters either from lung through a ruptured vulla or from chest wall through a penetrating wound, whereas open pneumothorax is accumulation of air in the pleural cavity because of an open penetrating chest wound. Air enters and leaves through this wound just like a thoroughfare channel during inspiration and expiration respectively. Now the tension pneumothorax. It is a dangerous condition which develops when chest wall tissue and or the overlying clothing behave like a valve, which allows air to rush into the pleural cavity but does not allow it to exit during expiration. Hence, air pressure builds up on the affected side of the chest, which results in collapsed lung on the affected side, mediastinal shift towards the opposite side, and compression of the opposite lung by the displaced mediastinum. Hydropneumothorax, abnormal presence of air and fluid in pleural cavity, which on upright chest X-ray shows well-defined horizontal air fluid level which extends across whole of the length of one hemithorax. Hemopneumothorax is presence of both air and blood in the pleural cavity, and pneumothorax is presence of both air and pus in the pleural cavity, whereas empyema represent presence of pus without air in the pleural cavity. Now the pleural effusion. It is an abnormal accumulation of fluid in the pleural cavity. Causes include inflammation, tuberculosis, malignancy, or congestive heart disease. Presence of fluid in the pleural cavity produces a number of signs. Like number one, lung is compressed on the affected side, bronchi are narrowed, breath sounds are faint, and dullness on percussion over the effusion site appears on the affected site. Both the X-ray left of male and right of female show right-sided pleural effusion, which is indicated by an opaque shadow with crescentic margin. Do compare right side of each X-ray with left side of its own. There is huge difference of opaqueness on the right as compared to the left. Ultrasonographic imaging for pleural effusion. Notable thing is that left picture depicts normal image with liver and lungs separated by a thick line indicated by white arrow, the diaphragm. Whereas on the right side, there is a space between lung on one side and liver and diaphragm on the other side. This space contains fluid, the pleural effusion. The treatment for pleural effusion is thoracocentesis. It is an
invasive medical procedure through which we remove fluid or air from the pleural cavity for diagnostic or therapeutic purposes. Procedure is as such: person sits upright and lean on a table. A cannula or hollow needle is carefully introduced into the pleural cavity after administration of local anesthesia. Recommended site is 8th or 9th intercostal space in mid axillary line, preferably under ultrasound guidance to reduce complications.
Comments and suggestions will be welcomed. Thank you for listening and watching.